There we are, and we are live. So today, Colette and I, with another episode of Bio Rebels, are joined by Dr. Gabriella Korosi. And we are going to be talking about something that we all talk about behind the scenes, and that is the terrible state of healthcare. In fact, the reason for this podcast was when I listened to you, Gabrielle, on Hal's podcast tell the story about what happened with your ankle injury and how the health insurance and the healthcare industry let you down. For those who didn't hear that story, would you like to briefly share it again?
Well, I was just sharing that as, as an example, but I have seen it many, many times that basically we have to go through hoops to get to the service that we need in healthcare. So, part of it was for inflammation to come down in my ankle, but another part of it was the excuse I got was that, the MRI is expensive. But because of all this, I needed to wait 5 months and I had to try physical therapy first and all these different things and occupational therapy and go to this specialist and that specialist before I actually get the MRI I needed for my ankle that find out that there's actually three different things wrong with my ankle and needed a surgery like pretty much right away. As soon as I get my MRI within a week, I got the surgery what I needed. The issue was that during this time, I have already used up I had also a brain injury and other things, but so I already used up my FMLA, my leave, and all that. So ultimately, I was forced to leave my job after my ankle injury because I didn't have any more leave. So it kind of things like just snowball when people don't get the care they need. So one thing
Yeah.
leads to another. But it's
And
just really important to, look at the whole person, not just one body part. There's more to us than a body part. And get the care that we need. And I also advocate for preventative care because reactive care is way too late. Let's prevent things before we get to reactive care as well.
yeah, which brings me to you, Colette, and you've always said that we treat illness, we don't support health.
Right. Well, this country is a sick model. We treat disease. We do not do preventative care. And I mean, I try to, I'm trying hard to survive every day, trying to navigate the sick model system that I'm trying to deal with because my patients want to use their insurance. But if you just look at the facts, you guys, on our U.S. healthcare, the failing U.S. healthcare, 13,000 per person is the average cost of healthcare in this country. We have nearly double most high-income countries. Now, let's just talk about life expectancy. The U.S. ranks worse than in many key areas than any other country, okay? We have a higher infant mortality. We have a significantly higher maternal mortality. We have chronic disease burden. Here we are with the most expensive healthcare system of obesity, type 2 diabetes, cardiovascular disease. We have so much preventable death here, and we have this, and people are spending oodles amounts of money on a healthcare system that clearly is failing. And it's not because we don't have good healthcare. I'm an amazing provider. I am trying so hard to. I ask Lee. I mean, I'm seeing patients all day today, and I can't. You feel like, and it sounds so like poor me, but it's hard to make money. Me and Lee had a reimbursement from an insurance company and you guys, these are the levels of care. It was I hear what I'm saying, $28. And it didn't even have 50 cents after it. Lee, it was literally $28. And I'm thinking to myself, how can I survive and what happens is this is the failing US health system. Doctors are going to private pay. They can't survive. And believe me, I want to take care of my Medicare patients and I want to take care of my Medicaid patients and I want to do it so badly that I'm willing to like kill myself all day long. And then they don't understand it on the other receiving end. This is why care is so bad in this country. I was working with a doctor that saw 100 patients a day, Gabriella, 100 patients a day. Now let's do the hours in an 8-hour day. You almost,
It's impossible. It's
it's,
impossible to provide good care like that. No.
I mean, it's impossible. So and I want to sit here and Lee and I talk about these, like, you cannot spend an hour with a patient. What are you doing? Because you can't. And I can't. And I have to recognize that. And that's where I don't criticize the level of education. The amount of resources we have in this country is absolutely unbelievable. Yet
Yeah.
we cannot offer it to the people that need it, the patients that desperately need it. And it's really only for the wealthy. Because that's what it's coming down to.
Yeah, there's no question about the providers. I love all my providers I had so far.
Yep.
I don't know if I had like a bad provider in the US without one ER doctor who basically told me I
Yes.
was full of shit. But literally. But
I believe it. Yeah.
most of the providers I see, they are amazing providers, but the difficulty is that insurance carriers
Yep.
dictating how you should run a business. And that's just really not working. And also, as you were saying, you need to focus on the prevention as a public health professional.
Yep.
I just love
Yeah,
prevention. Every dollar you invest in prevention brings so much more back to the investment.
But if you have a sick model of care and doctors have literally 3 to 5 minutes with you, all you focus on is the sick. You don't go anywhere near preventative measures. And in order to get preventative medicine, it's all out of pocket. It literally is. That's how you have to. This is where the discrepancy is.
More and more doctors in Manhattan, and I'm
Oh,
sure
yeah.
other cities are going pay, self-pay only. It's
Yep.
now not taking any insurance, because not only, also it's the fact that from a doctor's point of view and from like your point of view, both of you, it's very just going through the process of navigating a patient's insurance is very hard.
So
it's hard enough for me just
it's
writing it
awful.
down. It's figuring out how is it eligible for compensation? How much compensation am I going
Yep.
to get? Is this patient? I spend a lot of the time every day telling people we can't take their insurance, because we at this moment in time we don't have a contract for them, and even if we do, their insurance pays so badly. It's like, if we do take that patient, we have to cut their standard of care to a degree, because we don't have time to spend an hour on somebody who we're getting reimbursed less than a Starbucks worker for.
Yeah, Gabrielle, it's really sad, as now that I'm on this other side, is when I was a provider working for somebody else, now that I own my own business, I am really in it. I have to hire billers, I have to hire coders. I have to hire people to handle all the back end of this. And then how does a doctor really survive? This is why they're all going to big conglomerates. That's why doctors now, remember that, like back in the day, 20, 30 years ago, the doctor would set up their shop and you'd walk in. It was really mama and pop. It was family medicine at its best. That stuff does not exist anymore. You never get to talk to the doctor. Nobody has, listen, I'm dealing with it right now. When I left the practice, I was so spoiled because the doctor, anything I needed. Now that I'm on the other opposite receiving end, it's like, making appointments with people is so difficult. If they forgot to write a script, getting in touch with the office is the abyss. They never answer the phone. You're leaving messages. You don't hear back from them for weeks. And all you wanted was, like, I just needed pen needles for my insulin. You know what I mean? And it's so mundane. And even me, I sometimes forget to write in scripts, but me and Lee have decided that we are at all costs, and even him and I bickering all day long, we are there. I have to be there for my patients because I have been on the receiving side. I've been a patient my whole life with type 1 diabetes, and the just disaster that was, just trying to get in touch with the doctor. Like, I need to be accessible, which makes my life crazy, makes Lee insane. But I hope that people that come to my practice, anybody listening, I make myself available, that they should not have to wait a few days to get a medicine. And like in your case, you didn't even get the care you needed. And that is just criminal. And that the fact that doctors aren't, that my patients will say this too. I'm not practicing medicine. Your insurance company is, because they don't want you on Tresiba. They want you on Resglavar or Bastiglar or whatever. They're calling the shots.
But it's even bigger than that, because of how society is run and how all the advertisements are. Like, every time you turn on the TV or just out in the city anywhere, you see all the advertisements for different type of medication and things like that. And also, people think that just because it's on the TV, it might work for them. So they ask for the doctors to prescribe for certain things that might even not actually the best for them, or they are really expensive because they are the best brand new medicine.
Right.
even though there's the generic available that works just as well,
Yep.
and it's 1/10 of a price, there's a lot of confusion about, so who is prescribing what now?
Yeah. Well, that's who's prescribing what. So I
Is it
get
the pharmaceutical company?
it's so complex because I'm with the patient, which I spend a lot more time with my patients than the average doctor. And it's like you just said, we spend, and I have to tell my patients this, when I try to get them the best medicines I can. The time, Lee, talk about your experience with prior authorizations. How many pages
That was
how,
my next lead in.
7 pages, 10, talk about that. Because Lee does my prior authorization. So by the way, he's the mastermind. And it is, and I always tell people, it's not about the doctor. It's who's doing the prior authorizations. I mean, it really is, because if you want good medicine, your doctor better have a good prior authorization person.
And why do you even need a prior authorization, right?
Yes.
So you as a provider, you are a nurse practitioner, if I remember correct,
Yep,
right?
yep.
So you as a nurse practitioner, if you think this would work well for your patient, you should be just able to do what works well for your patient, right? Wouldn't that be
Yep.
simple like that?
Oh my God. If we didn't
But
have
I
the
remember the
insurance
days.
companies are making the decisions as to what is best for
Yeah,
your patient,
exactly.
not the
I
doctor.
remember the day in Hungary, after you give birth, the doctor and the nurse comes out to your house, assesses you and the baby and all this kind of stuff, and give you what you need and give you the prescriptions you need. No authorization needed, nothing needed. And I loved when there were house visits and things like that. I remember the doctor coming out to
Yes.
my grandma's house and all this kind of stuff, and they did what needed to be done. No insurance, no authorization. It was the doctor's decision, and the discussion between the doctor and the patient. I think that's how it should be, but maybe
No, and that's where doctors are getting so burnt out, because they're
yeah.
breaking us down. They're leaving medicine. I listened to somebody on Instagram. This doctor was like so inspiring, because I felt like they were her words were my words. She's like, "You guys are breaking me down. The field that I love most is taking care of patients. I can't
Yeah.
do. I can't do anymore because A, I can't survive. B, I mean, I'm working 12-hour days, 15-hour days to just finish all the paperwork that's necessary for billing. I got myself stuck in the situation where it isn't about my note being appropriate. My notes are great. I've always been taught how great my notes are. They're not appropriate for billing. I have to write in where the location is, the consent, um, all these little codes, and write the right documentation for the coding if it was an obesity code or sorry, CPD code. I mean, so my notes have to be like this. I mean, they're literally like they're like a novel in order for me to get reimbursed, and in order for me to get a G code that says G0108, which is a diabetes code, which I do all the time. I'm a diabetes educator. If I don't document that I spent 30 minutes, I mean, if I don't document it, you're not getting paid. You know what I mean? And so I had to go back to all my notes. It's been so intense, Gabrielle. I mean, and Lee helped me. I mean, I have to code everything differently in order to appease, not me, to appease the insurance company, to appease Blue Cross Blue Shield, to appease Fidelis, so that they're happy, and then they can, because they don't want to pay the doctors. For everybody listening, your patients are like, "Oh, I just call the doctors. I don't understand. They should just write the medicine. I don't know why I have to make an appointment." You have to make an appointment, A, for me to do quality of care and make sure that we don't need to increase or decrease the dose. But now I know on this end, in order for me to even survive, I've got to write the appropriate note with the appropriate medication and the change. And like, patients don't even get, like, we had a patient the other day, "Just send me the medicine." You know what I mean? I'm like, "I haven't seen you in 3 months."
Yeah.
It's not that easy. And they don't want to go to I don't know why I need a visit. You need a visit. It doesn't work like that. You know what I mean? Doctors have to serve. We have to survive. We have to do quality of care. It's such a burden on, like, the entire story of what I'm trying to do. And I'm not complaining. I love the patient care. It really does break you down. It breaks all of us down. And I see it over and over again with doctors leaving practices and going private pay. And concierge medicine is not cheap. It's not going to be for everybody. It's $2,500 a year for like a membership. And then you're paying additional fees, and 25, I mean, I don't know if we should bring up the name, because it's kind of got a, but Peter Attia, before all this breakdown of him, he was charging $150,000 a year to see basically an anti-aging or functional medicine, and where this new way of care is thinking preventative versus sick model, but that is at a cost. And again, it becomes an elitist model. You know what I mean? It really, and how do we bring up a society as a whole? How do we bring up a society as a whole to become a better functioning society if, like you said, we don't do preventative care?
I think we have to. I think what we can is what we are doing now. We can inform people.
Yeah.
And the more and more people think about preventative care, and the more and more people recognizing what the sick model is, they might start to ask for it and start to,
Yep.
start basically roots movement, a ground roots movement for asking for what they need. There are some insurance companies now that they pay for preventative care. So I do
Yep.
want to give credit for that. And I think the other thing that I have seen that is positive is more and more workplaces recognizing the need for
That's true.
preventative care for the employees, because people are burning out and they are leaving the workplace because of depression, anxiety, diabetes, like what
I
you're
know.
working on, which
Yeah.
is thank you for working on that. It's such a number one problem.
Yeah, I know. We have a whole battle ahead of us. And I think what was interesting, because of the drug prices and how incredibly we have the highest drug prices anywhere. Um, and it's crazy to think like this, but even other endocrinologists I've spoken to, we are aware of Canadian pharmacies, and we are aware of alternative avenues to get medications at much cheaper, because it doesn't the insurance sometimes isn't covering the medicines that they absolutely need, and you can actually get Mounjaro in other countries for a couple $100. And here in the States, without a prescription, it's over 1,200. I mean, it's obscene. I mean, Tresiba, an amazing insulin, pennies. It's incredible, like just the discrepancy in cost on drugs, which is what I will say. Mark Cuban, a billionaire, I mean, whatever the case, he did come up with cost plus drugs, and cost plus drugs is a Mark Cuban uh, originating service that anybody, actually, you guys, if you go on Mark Cuban, there are very, very popular drugs at half the cost. So it's if doctors in the know, I actually use Mark Cuban a lot, because certain medicines are just much cheaper, and they're not going to be covered by insurance. So they are at a reasonable cost there. It's just another frustration when patients absolutely need something like a Repatha. The PCSK9 hyperlipidemic drugs are absolutely amazing, and in terms of how they work, being a monoclonal antibody, they really work towards just one system on the body, like working on an enzyme, just breaking down the enzyme. So the side effects are it's an injectable. It just works so good, and it's so expensive. I mean, some of the most amazing drugs, like there's in this, I don't have it handy here, but like 6 companies that are making Zepbound. This would be for weight loss, making Zepbound on formulary. So we know this. Like 3 years ago, it was much easier to get covered, and then everybody just wants money. So now they're going to make a cash pay.
Yeah, good
And
idea.
honestly,
Yeah.
obesity is, if you look at the statistics on obesity, you have more missed work, you have more chronic conditions, more cancer. It's really all-cause mortality. If I owned a business, I would have Zepbound on formulary. These people will lose weight, they will become more productive, they will work harder, they will have a better just system balance. I mean, I work with this medicine all the time, and the benefits are just incredible, yet almost impossible for somebody that's struggling in a middle class
Also, when people
economic
spend money
state. Yeah.
on health insurance, they wonder why their drugs aren't being covered.
Oh yeah.
They're spending all this money a year or a month or, whatever. And then they're wondering why they can't get the drugs they want, because their insurance company doesn't cover that drug. It will cover a a lesser drug, maybe, or a less effective drug, or a drug that's cheaper for them. Although there are instances where that doesn't happen, like the one we had recently with the insulin, Novolog,
Yeah.
where the formula was not Novolog, which is a long tried and tested insulin.
Yeah. Old
The
insulin.
formula drug was Lumia, which is a brand new, much better insulin.
Right. Well, there you
That was
go.
the one thing that really worked for them.
Right. The bureaucracy, though, because the pharmaceutical companies make deals with the PBMs, like your pharmacy benefit manager. It's all about money. So they're making deals, and then they throw on their new, their drug to throw off Novo Nordisk. I mean, it's like, who's in bed with who? I mean, you guys, it's really, it's almost crazy. I mean, to think that we're even having to deal with this. The doctors have zero say in what they want to give for their drug. In that one instance, we were lucky, but
Yeah.
right now it's
I think
navigating a
this can
system.
be very controversial because I can understand both sides. I can understand that developing a new drug costs a lot of money, a lot of research, a lot of controversies sometimes. So I understand that the pharmaceutical companies have to make money. On the other hand, I do feel that medications that are life-saving medications and that are essential medications for people, they need to be provided in a price, however the government can support, or whatever way the insurance coverage, so people can afford their heart medications, their diabetic medications, and things like that are literally life-saving. When I grew up in Hungary, some of these medications were given in a black prescription. It's meant that if it's written in a black prescription, you take it to the pharmacy, you don't have to pay anything. You don't have to pay anything because it's a life-saving medication.
Yeah.
And otherwise, the doctor can write on a prescription based on knowing the patient, knowing their income level, what the patient can afford. So the doctor can ask the pharmacist to give it at a discount for a patient to be able to buy the medication. When I was working in a cardiology clinic a few years ago, it was heartbreaking. It was absolutely heartbreaking to see Medicare and Medicaid patients getting into this donut hole, which means that after a certain amount of money that they spend, they could not afford their medications. So we tried to cover with samples, with discounts, with coupons. And many times we have to switch the better medication into a less effective medication because they simply did not have the money to buy the medication. And it was so heartbreaking to see. And I wish there would be a solution. And I don't know why, of all the politics of why is it more expensive in one country or another. I just wish we would go back. And I know it's difficult to go from a reactive medicine to a preventative medicine, but there's a reason for in a first base, why people have cardiac conditions and why people have obesity and why people have all different type of diseases. It's the type of foods that we eat. It's what's in our environment. It's the type of society we live in. So we can go back to the basics and say how we want to live, what type of foods we want to eat, and start from there. So I think education is essential. It's hard because people see what they see in TV and see what they see in advertisement and see what they roll on TikTok and Instagram, all these kind of things. But I think every pearl of education that we can provide, about fresh fruits and vegetables and microplastics and all those kind of things and hormone changing agents is helpful. Every little thing we can do with prevention.
Yep, I know.
Your camera just went off, Colette.
Yeah.
Okay, sorry about that.
Yeah, and I'm going to move on to another subject, but before I move on, because I know we're going to cover two subjects today, but before I end this subject, what do you guys think is the solution? If somebody tasked you with finding a solution, I mean, I know that's an impossible thing to answer in a brief thing, but what would you say would be the solution to the current issue with health insurance and health, just in general health treatments, the way they're, the way they're handed out just now? What would be your solution to the current healthcare crisis, indeed?
I mean, I think Gabriella said we need cheaper drug prices. We need better negotiations. I know, listen, I understand this is the big problem with what's going on with tirzepatide and retatrutide and how much money that research and development cost at a pharmaceutical company. It is billions of dollars. Billions. Those studies are not cheap. They're incredible, right? I mean, they give us a wide variety of data, and most physicians are evidence-based. So I totally understand that. But there has to be, I mean, I think it's really comes in with the drug pricing, because this is where the prior authorizations come into play. This is where we have all the issues because patients cannot get the drugs they need to be healthy. I mean, and that's really what Mark Cuban did. And he tried to figure out a way to make the drug prices cheaper, like they are in other countries. I mean, I really, it's beyond my pay grade and understanding how this all would work, but I just know that drug prices in this country are amongst the highest. So that alone is putting us at a disadvantage, and one that I think, we're trying to tackle. It needs to be tackled. Um, and then, when it comes to private insurance, I mean, these people, that is, I mean, the insurance coverage these days, again, we're paying like $13,000 a year. So the Blue Cross Blue Shields, your Fidelises, your Cignas, I mean, their premiums and out of pocket deductibles, look, they tried to do it with Obamacare. I mean, it's such a it's either which way you're going to go. Are we going to have socialized medicine? Or are we going to figure out this model? I mean, either way, no one's happy. So, and we tried Obamacare and people weren't happy there either. I mean, so I don't know, Gabrielle, I'm willing to listen because I don't really know where I mean, I would hate to be on that board because I wouldn't know which way to go either.
I think focusing on wellness, like rewarding doctors and companies when you keep the patients well, when you keep the population well, would be a great step toward that. And I do believe the basic right for healthcare. So I am all for Obamacare.
I
I
know.
grew up in socialized medicine. It's not perfect, but it is 99% better than what we have right now. I do believe everybody needs basic health care, basic rights to go to the emergency room and not have to lose their house or have to end up in debt or end up in thousands of dollars, that they cannot pay because they have to see a doctor, or God forbid, die because they are afraid to go to the doctor. There were times when I didn't go to the doctor. I could have gone. I'm a nurse. I figured it out myself. I stitched myself up or glued myself together because I did not want the $300 or the $600 or $1,000, $1,200 bill of going to the doctor. And I think many people wait and not go to the doctor because either the doctor is not available, we don't have one, it's 3 months scheduled out, or it costs so much that they can't afford it. So focusing on wellness and providing basic healthcare for all is what I'm going for.
So moving on to our next subject, Gabriella, I was interested to see that you'd written, amongst the many books you've written, shall I say, you've not just written a book, but amongst the many books you've written, you wrote one that about addiction, which incidentally I downloaded on Kindle the other week. Because I was interested to read it. I just started reading it last night. And I was just telling Colette, I found the introduction interesting when you were talking about hummingbird, which was the last thing I expected to read in the first chapter of a book about addiction. Can you, but what is your own experience with addiction, and what inspired you to write this book?
The inspiration was that I was working as a nurse for about a decade, working with people regarding addiction. And before I started work, I had my own biases. And also in my family, there were people who died because of addiction or suffered because of addiction. So that was my inspiration. And in this book, I wanted to kind of create a whole story because many times there's a story of a patient, of a nurse, or a family member. And I wanted to put it all together, looking at from the perspective of healthcare providers, family, the people who suffered with addiction, the people whose family members share the story if somebody died because of addiction and what happened. And also look at anything from nutrition, from government. So I was trying to interview as many people as possible to kind of create a more holistic picture and try to provide some solution and just tell the story, because I think we do learn from storytelling. And I did feel that it's an important story to tell. And from the beginning to the end, it took me about 6 years to finish this book, for various reasons, including going for my PhD. But I do feel that it does provide an accurate picture. And it was kind of a snowballing effect. There's stories from my family, and I some of my coworkers, friends, and then they told me about somebody who had another story. So it kind of snowballed. So there's about 50 interviews that are in the book and discussion about addiction and what I have seen and experienced as well as a nurse.
And Colette, in the future, at some point in the future, you want to write a book about your journey with someone who was the victim of addiction. Can you tell us about that?
Well, I was I have actually, living with type 1 diabetes, I tried to like avoid any substances. Like I've truly never been drunk in my life. So I had I've been around, especially as a bodybuilder, I've been around more performance enhancing drugs. But when it came, and also recreational, but when it came to like just hardcore addiction, I like to think I was like a bit naive as well. So I ended up just falling madly in love with somebody that, um, this is where I want people to understand the face of addiction is not what you think. This was a person that was struggling with a lot of demons, and his only coping mechanisms, unfortunately, happen to be two of the most, heroin and crystal meth could be, they're so the crystal meth is getting you from the dopamine hit that you cannot get. It's something like 100, you can look at where the dopamine fire is. It's way above anything, even cocaine, anything. And then you have the physiologic dependency of heroin, and watching the two together in a person that really is just a person, and everybody judges them as if they're the rot gut of society, and then they don't understand that I knew this person to like want to be sober more than anything else, and it's all and you would never think that, you know what I mean? Because you're like, how come you say these things but yet you cannot do them? And I did not process that. I'm like thinking, if I could have done this all over again in what I've learned about addiction and understanding of it, my frustration was only making it worse. You know what I mean? Because I couldn't see behind the shell of just, why are you doing drugs? You know what I mean? And it's so much deeper than that. And I've just became like kind of, at one point I thought about going into addiction medicine, and it didn't happen because I fell so madly in love with just the alternative piece of preventative care. But where I studied, where, the idea of being on, some patients will have to be on like a Suboxone or a Subutex because there isn't another way. And it's better than going to use street drugs. And I would love the reality of them being able to get off all drugs and cognitive behavioral therapy and, rehab and all that. But rehabs typically don't work. Rehabs, my dear, ex ended up in 7 rehabs, and none of them worked. And he kept saying, none of these. I said, you have to be able to work this system. He didn't have the tools. He was looking for some kind of magic when you went to rehab. That never happened. He lost his life to drugs. It is just it's such an unfortunate battle. Like 3% make it. 3% are able to truly, absolutely like be off all substances, right? Most of them are going to need help. And that's where I kind of changed my tune with using like a Suboxone or a Subutex, because it's better to use a prescription drug that is partially agonist of the opioid receptor than do street drugs. It would have been better. And I've seen, through knowing him, his friends that are on, one of these agents, and they're able to at least function in society and not run the risk of an overdose. Because what's out there right now is not good heroin. It is not good crystal meth. It's all tainted with God knows what. And some of these cutting agents they're deadly. They're absolutely deadly. So
Yes.
it's so scary to me, because addiction is, my uncle, who is blind. This is just an absolutely crazy story. He was a heroin addict. I didn't even know this. I hardly knew that he was blind. And he worked with my father at a company. It's a family business, so he and them were partners. And my dad told me, he's like, Ronnie has a very serious, and I knew him. Like, he was a functional heroin addict when heroin was actually cleaner than it is now. You know what I mean? He would go to work. I would remember seeing Ronnie. And he ended up actually, unfortunately, his girlfriend, they together were functioning heroin addicts. She had to shoot him up, and he ended up dying. Unfortunately, it was this is what can happen. So then it goes back to, if we need to use these other agents in, you know, getting a patient truly off of the street drugs, and onto something like a Subutex or a Suboxone or what have you, then at least they're on something that is from a pharmacy, that is in a predictable dose, and that they can function in society and they can live a normal life as best they can. Because something is, you know, it's so deep addiction. I mean, I think this is a very huge missing piece, is how do we treat addiction? I don't know, Gabrielle. I mean,
Well,
I
I
don't
think
think we're,
one of the fundamental problem is that people make the assumption, the same assumption that you were making. Why don't you just get off of dogs? Well, why don't we just stop eating? Why don't we just
yeah,
stop drinking water? It seems so simple, yet it is so complicated because the brain is basically hijacked. The
yep,
brain cannot function really well. And when your brain, all it can think of, what I have learned based on
yeah,
addiction medicine that I experienced, is all they can think of is the next fix, the next dose. That's their whole life is. And when that's not happening, they are in severe pain.
yep,
And the body cannot make any dopamine anymore. So for people who don't know this, dopamine is like, okay, now the three of us have a great conversation. We can smile. We have a good time. That's a little dopamine release, right? This is going to go on YouTube. We're going to get 1 million likes, 10 million. We are happy. We're smiling. Oh, that's great. It feels good. That's a little dopamine release.
yep,
But when you're taking drugs, especially something like heroin, then it is hijacking this dopamine and give you huge doses,
yep,
like millions of times higher than our little smiles. So it kind of depletes the dopamine. And then people keep chasing this high, but it's not coming. And at this point, it becomes painful. It becomes so much pain, then they are just trying to relieve the pain. Now, even if, and that's why many times treatments that you're mentioning failing,
yeah,
because the brain needs minimum of 6 months, but most of the time a year to recover enough that people can start to have the normal little dopamine releases. And this haven't even touched the issue why the addiction started in the first place, because many times there's a painful event, a trauma happening before the addiction that you also need to deal with, and during the addiction that you also need to deal with. So it is extremely, extremely difficult. And I have seen people, I didn't understand addiction until I have heard stories of young women being injected or being given alcohol or drugs at age 5 and
ah,
6. And when I heard those stories, then I understood
yeah,
it had no sense. And I know some people can make a choice. There's some people who just came from such a societal background, such a painful rape, murder, abuse,
yeah,
that they didn't see anything else. And yes, you can make a choice. And then there's success stories. There's amazing success stories, even in my book. There's amazing success stories that I have seen, but it is a small percentage.
it is a small,
It can be. There's the
they say less than 3%, they say.
there's
That's
the
the,
needs. We need the emotional support, societal support from the beginning to support these people. But I agree that Suboxone, Subutex, Sublocade, Methadone, whatever you choose to help people stabilize until they can get off, or they might have to stay on for the rest of
yeah.
their life, is still better than taking state drugs that could be cut with
See,
fentanyl, could be cut with things that
yep. This is
really,
where we have to remove the stigma from addiction, though, as a
yeah,
society. Because if we did
right.
that, maybe we could help some of these people that are because again, we are not good as providers. We have this implicit bias that is just not okay. Because I think there's people that we could help more with these tools that we have right now. That's what
Yeah.
we've got. Is what you said. These Subutex, even naltrexone, Vivitrol. I mean, we have, I don't know. I feel like it's so sad because I watch somebody I love, you know, that's the watching them just fade away and then they end up dying of an overdose or just from depression or not being able to get the drugs. And that is what, I mean, Lee, we and I have spoken about this. We wish, we were so naive to, like you said, it's not about, can't you just stop? And now I'm going to get really mad. It just, that doesn't,
They can.
It's not that simple.
No, it's
And
very,
also the
addiction
rehab.
medicine is very, very complex
Ah,
and complicated. And there's so many layers. It's like with any disease, but like triplet, all these layers of onions because
yeah.
you deal with the addiction. One of the most difficult was for me to understand is when we were dealing with pregnant women who were addicted,
Ah,
that, it was hard to get my head around at first that they were not pregnant first. They were on a dick first. And then many times the pregnancy just accidentally happened. So they were not there to
yeah.
protect babies. They were not, many times they didn't care about the babies, which was
Yeah.
for a woman who had children, it was
We're
really
like,
difficult.
I don't understand why. Yeah.
But many times those were accidents, unfortunately, or many times rape or whatever it
Ah,
happened. But sometimes this helped them also clean up because they realize,
have a baby.
that
Yeah.
there's a life inside of them. But many times we see women being pregnant 12, 14 times and they never got out of addiction. So it can
Ah,
go either way. It's addiction is a very, very difficult situation. And
yeah.
it's very hard I'm sorry you had to saw, your loved one going to
Ah,
that. It's very difficult for family and friends. Many times the family drowns in it too.
yeah.
And what I have seen is one of the most difficult things for family is to set boundaries. Because unfortunately, sometimes you have to set boundaries so you don't sync with the other person. Because everybody can sync together, or you can set boundaries.
Right.
And it could be difficult, but it can help the other person clean up. Yeah.
And what I was going to say is that the rehab model as it is doesn't work either because you're putting somebody into a rehab for 3 months. And I watched a TV show just recently. I can't remember where it was on. I think it was on Amazon. About it was an older show, but it was about how ineffective treatment for addicts is. And there was like saying you can't treat addiction in 3 months. You can
No.
start
No.
the process, but it takes years, and then it takes
Yeah.
the life. It's in a
And it's an
lifelong thing.
everyday process
Yeah.
forever
Yeah.
once you're in it. Yeah.
It's
So they
like
talk.
for an
So
alcoholic, it's like they can never drink normally. They have
Yeah.
to abstain for life.
so
Sorry,
this
Claire.
is this is what I was trying to point out about with crystal meth, you guys, which is to me like the biggest poison ever. The relative dopamine increase. So you look at a baseline of 100%. Let's just look at a baseline of 100%. Food, 150%. Because we know food addiction, like you said, food addiction is real.
Yeah.
Okay, we can kill ourselves with food. Sex, 200%. Nicotine, very addictive, 200 to 250%. Alcohol, 250%. Cocaine, up to 350%. Amphetamines like Adderalls or what have you, 400 to 500%. Methamphetamine, like a methamphetamine, 800 to 1,000 times dopamine hit of baseline. It is so incredibly addictive to the brain. Like your point, your brain is going to be depleted absolutely at zero. And like you said, I couldn't wrap my head around it because I'm a high energy person and I'm like, you can fight it. I used to say, come on, be strong.
Yeah.
Just say it. It's not about it's nothing to do with that. I used to say to him, I'm like, come on, don't be weak. And believe me, I am so upset about myself because I was so naive and like, I was going about this all wrong because it isn't about that. I don't know what that feels like to have that, like you said, that nothing to drive, nothing to make you even care about life. You know what I mean? And it is something else. It is
Well,
something
and it's even gets more difficult than that because what methamphetamine does to the brain, I don't know if you have seen cross sections of the brain with methamphetamine.
I did.
One of the addiction conferences I went to, they were showing us cross sections of a methamphetamine brain, and the brain had holes in it. I was like, oh my God. And many times, even if somebody recovers, they're gonna be mentally ill.
Yep.
Because they cannot fully regain the functions of the brain and can develop hallucinations, schizophrenic type symptoms, other mental health issues. So it's extremely difficult unless you can catch it early and the brain can still recover.
Yeah.
Once the methamphetamine, I mean, they're toxic. So once these chemicals, especially people make household, all kinds of crazy stuff, once these chemicals literally chew through your brain, there's nothing to be done. Like the person, who it was, we lost them, and it's tragic. And if the more we can do to support people in mental health, community building, to prevent these things, would be great.
Well, here's what's even scarier to your thought and to the young people listening to this. I mean, I'm not a holy roller, although sometimes I feel like I'm a holy roller, but your brain is still developing until you're 25, 26 years old. And yet all these young ones are,
Especially for men.
yes, especially for men. What about the ones that are experimenting with, a lot of experimentation happens in the youth, and it scares me because
It's scary.
what about marijuana? Everyone's like, oh, marijuana, like nobody cares. But believe me, there
Oh
is
yeah.
Yeah, I just read something. I wish I could
yes.
remember what it was about new research that is coming up about people going to emergency rooms with symptoms of an illness caused by consistent marijuana use. And I
Well,
wish
and
I
it
could
kind of
remember what it was.
but it depending on the level,
Yep.
what it, again, you don't know what's in it, and also it's been proven before that it changes things
It
in
does.
the genetic makeup even. So with a developing brain, just don't use anything.
I know. That's what I feel like, I'm not saying this about anything, but I never used anything. Because I mean, having type 1 diabetes, look, you have to make it you got to make your blessing into it rather than a curse, right? Because I did avoid all these things growing up. And, listen, I had a second career later on in my life, and I graduated summa cum laude. I'm just saying, I do think that these young brains, there needs to be more education. I mean, maybe if you knew, right? I mean, I know everyone's like, your brain on drugs, and that was a big ad back but that's literally true. You know what I mean? The fried egg. I don't know. Like, Lee, did you ever see that? It was a commercial here in the United States. It was like, this is your brain, your egg, right? This is your brain on drugs. They show it frying. And that, I think to your point, Gabrielle, you made a perfect, analogy to that your brain changes. I mean, you're seeing these,
I think people don't believe it unless
they don't
they
believe it.
know somebody. And that's why, like, even in the book that I wrote, I was trying to actually talk to people. Like one of the stories was
Yeah.
devastating because it was an accidental opiate overdose of a young mother.
Ah,
Because she had post-surgical pain and she got a pill off the streets that was laced of fentanyl. She took one pill and she died, like literally in their 20s, prime life. And it can happen to anyone, anywhere, buying something because they don't know what's in it. And they might think that they're going to have a party of their life and not waking up. I know mothers who lost their sons and daughters, and there's nothing more painful than losing your child. It is extremely painful. The same with alcohol. People think, oh, I just drink. Yeah, well, some people can stop. Some people
some people
cannot
can't.
stop. And if you're drinking every weekend or if you're drinking every night, it's an addiction and it's just going to
Yep.
get worse and worse. So it's a very complex situation for sure.
Yeah.
And for the youth listening, please don't do it. Your life is more precious than
Your life is
this.
more precious. And what we do now makes a difference. You always think that, you're invincible as a young one. I
Yeah.
mean, and what you're doing now, even those pivotal years, like 15 to 25, like it impacts sometimes the rest of your life. I mean, there are people that got skin cancers. I mean, those sun bunnies, that was like one of my best friends got. I mean, yeah, right. I mean, well, but that those, we used to just bathe in the sun all day. Now we know otherwise. You know what I mean? Like what we did then does matter. And I think we just often take it for granted because you do feel invincible. I felt invincible, in my youth, and the injuries that I've acquired was a lot of things that I did, between the ages of 15 and 30, really. I mean, I was just thinking I'm invincible. I've had 5 shoulder surgeries, now 7 because of my arm. I've had 2 arms. I mean, and it's just this, this notion that, I'm good. Nothing's ever going to happen to me. And like your thought, you don't believe it. You don't believe it. You know what I mean? Until it's so close to you or until you're experiencing it yourself. And it's unfortunate. Like a lot of the words that we speak, people are like, that's not going to happen to me, So it's not true. It
Yeah.
does happen and it can happen. And we just need to do things to avoid it.
Yeah, yeah. And to round everything up for today, and by the way, thank you both for this. This has been great. There was one thing I wanted to cover real fast at the end of this. It was that we're on the subject of addiction again. The promise that some of the SGL P drugs are
The
actually
GLPs, yeah.
GLP drugs are giving in that they're showing promise in treating addiction. The likes of the Ozempics and the Wegovy's and because they're attaching themselves to the brain centers that can actually, without even they're in there stopping food addiction per se by nulling the appetite, they're also nulling the appetite for other substances.
Right. Well, it works with GLP-1s. We have receptors in the brain and they work on the reward system. So it's like the hedonistic part of your brain that desires things and wants things. So I feel, well, they're actually going to come out with a drug. I think it's either Novo or Eli Lilly with another name, but similar. It's, they like to name the same things and give it a different indication, but where they are going to use it in addiction medicine. And I think like what we're learning more and more about addiction, it's different tools in the toolbox, like where they use naltrexone because it's a partial agonist on the opioid, and same thing with Subutex and Suboxone. But I do feel, because I truly was a food addict with a horrible eating, like binge eating disorder, and I don't do it. It changed the way my brain desires. It's not going to be for everybody, but I think a lot of my patients, at least with alcohol, especially, that's where I think the indication is going to come out for alcohol to just help with calming that desire. Of course, there's all the, AA has been very effective, but, many other tools that are in the toolbox to aid in that addiction behavior. But I do think that there's going to be more important research coming out about using the GLP-1s and as the new iterations come out to help with addiction. So I'm very hopeful on that. And I actually did at one point, because diabetes is my specialty. I had wanted to do that with my boyfriend. I did. I was like, maybe I just thought, you know what I mean? He didn't need to lose weight. You have to understand, forget about the weight. It's how it worked on the brain. I mean, I will never know that answer to that question if it would have made a difference. And I think there's many deeper stories there, but I'm interested to see. Well, I think it's a wait and see kind of thing, but I do think they're definitely going to be used in addiction medicine.
Yeah. Anything you'd like to say to round things off, Gabriella?
Well, I just wanted to say that, addiction and any type of disease, medication is just one thing. Another thing is the emotional, the mental health support, and also to have a community of people and to look at the person as a whole, from a whole health perspective. The person is not just disease. They might have a disease. They also are a living, breathing human being. They have an environment. They have a place they live. They have a family or don't. So, look at a person, look at all the layers.
Yep.
Not just look at a cardiac condition, not just look at an addiction condition, look at the whole person and look at every step what we can do for prevention and wellness. Because the more rounded the person, the more support, the more community, the more wellness, the more environment and nature and all these kind of things we can bring in, and mindfulness and meditation, they are all part of it. Sometimes the simplest thing we can do is just help the person pause and breathe, because we forget in this running crazy society to just breathe. And that could be just such a calming thing that they can say no maybe for the next, time they go out and want to have alcohol or something else, because they feel that there's other people to connect, there's other things that are important in their life. I think many people get lost in this cycle in society and forget to pause and kind of connect with themselves and what they want in life. So the more we can help people do that, I think the better off we are going to be.
Okay, and on that note, thank you
Love
so
it.
much, Gabriella. Thank you, Colette, again.
Thank you so much.
Thank
And
you for
we'll be
having
back
us.
again for another episode of Bio Rebels covering who knows what. All right,
Awesome.
bye.
Thank
Bye,
you,
guys.
everyone.
Thank you. Bye, guys.
Wrong one. Stressing in, but nothing's happening. So it's me and Gabriella saying good night from me, and
Bye.
just sleeping us in.